First, I'd like to thank all of you for coming tonight and joining us in our struggle with Castleman's disease. Let me see. Okay, there we go. This is the famous man himself, Benjamin Castleman. I would like to invite all of you to become a Castleman champion or warrior to help fight this disease. Last night we gave out the inaugural Jim Johnston Castleman's Warrior Award for an individual making an outstanding contribution to the field of Castleman's disease. This award will be given on an annual basis. Jim was given this award because he started the International Castleman's Disease Organization in the 1990s. And really the baton is handed over now to the younger generation. And I think that David has done a marvelous job in spearheading the Castleman's Disease Collaborative Network. So maybe one of us can win this award someday if we find, if we can figure out the etiology of this disease. As David pointed out, Castleman's disease is a so-called benign disease. However, we actually are doing better with malignancies such as myeloma than treating with this disease. I think part of the reason that survival is not good is because many patients get managed in the community by physicians who are inexperienced with this disease. They may have seen only 1 or 2 cases in their lifetime, and they don't give the appropriate therapy, or if people are very sick, they're scared to give chemotherapy to a sick patient who doesn't have cancer. So I think there's a lot to be said for some form of centralized care, or at least direction of care for patients with Castleman's disease. When you see patients in the clinic and you think how they behave, there's sort of 3 major phenotypes. There are these, You have the patients with the major cytokine storms. The patient gets severely ill, go into organ failure, sometimes renal failure. They wind up on the ventilator. And this may be referral bias to my particular center, but they seem to be the younger patients when I think about it, not the older ones. Then the patients with the waxing and waning or slowly progressive disease. And sometimes they can incur incipient organ damage, such as here fibrosis of the lungs in an oriental patient. Then there are patients who have multicentric Castleman's disease, and the disease appears to be more indolent. Now, these patients, in my experience, if you work them up carefully, they have some sort of feature of POEMS. They don't have the progressive motor polyneuropathy, but finding some osteosclerotic bone lesions, as you can see here in this particular patient, or 1 or 2 other features of POEMS is not that uncommon. So there is this spectrum between Castleman's and POEMS, and there are also patients who have both. And I think especially Dr. Dispenseri has a lot of experience with that. So there is correlation between the 2 diseases. So what do we do with Castleman's disease? I think apart from one randomized study, all studies mostly rely on small case series, case reports, or analyses of the literature. So a whole host of different therapies have been applied. Steroids will work in the majority of the patients, but you need to keep them on fairly high dose of steroids, and if you taper, it flares up. Rituximab I'll talk about more later It has definite efficacy in some patients. In my view, it's not single-shot curative therapy, and the majority of patients eventually will relapse. Some patients need some form of combination chemotherapy, particularly when they're very ill. And there have been case reports of using alpha interferon, alpha-retinoic acid, cyclosporin, sirolimus, bortezomib, thalidomide, lenalidomide, anakinra. And then there are the anti-IL-6 therapy. Suramin doesn't work. There's the tocilizumab antibody against the IL-6 receptor, and the novel drug Siltuximab, which targets IL-6 directly. And lastly, there have been a few cases of Castleman disease which have been transplanted. I also know of two patients who've actually relapsed after stem cell transplant. So what's exactly the role of stem cell transplant is, I'm not too sure. David already looked at the literature and was able to isolate 129 patients who were well defined. Conversely, it seemed like the majority of case reports, we don't know too much about their virological status. There is limited follow-up. So the majority of reports has not been that helpful. And I think that David is quite right. You tend to report your successful cases and not your negative outcomes. Or if you give a drug and it doesn't work, then you don't write it up in the journal of failed therapies. So IL-6 obviously is of importance in Castleman's disease, and Dr. Bart Barlegi actually was the first one to use a monoclonal antibody for this disease in 1994. The antibody had some problems. It wasn't very that effective in terms of binding, had a short half-life, but it did have some effect in a single patient together with other additional therapies. So the anti-IL-6 therapy was already used in the 90s. In Japan, particularly in Osaka, humanized monoclonal antibody has been developed, which binds to the IL-6 receptor. Oops, I said this wrong. And prevents IL-6 from binding to the IL-6 receptor and prevents signaling to the GP130 complex. It binds both the soluble form and the membrane-bound form. So this was studied in a series of patients in Japan in a single-armed study. And you can see that the laboratory parameters improved very nicely. The CRP went down, hemoglobin up, albumin up. And these are some of the parameters you can also use to see if your patient responds to the therapy that you're given. They also saw that over time, there was shrinkage of the lymph nodes. Again, the improvement in symptoms is rapidly, the improvement in laboratory parameters is rapidly, but this is not a cytotoxic agent, so you merely take away the growth signal for the lymph nodes, and the reduction in lymphadenopathy is gradual. Then there is Siltuximab, which directly neutralizes IL-6 and has a similar effect as tocilizumab or Actemra has. This is one of my patients who was treated in the phase 1 study with Siltuximab, who had a large mediastinal mass which completely resolved after 2.5 years of Siltuximab therapy. He's still on it, tolerating it very well. And in his case, this therapy was very effective. The success in the phase 1 study led us to do a randomized trial with patients with HIV negative, HHV8 negative Castleman's disease, conducted in multiple countries all over the world. Patients were randomized either to placebo or Siltuximab, and they could receive best supportive care, which was up to 60 milligrams of prednisone or equivalent. If patients failed therapy and they were on placebo, then they could cross over to the Siltuximab arm. So the primary endpoint was complete tumor and durable symptom response, which was achieved in 34% of patients and none in the placebo arm. The time to treatment failure was superior in Siltuximab treated patients. And if you look at the tumor response, both in independent review and investigator assessment, that was also clearly superior in the Siltuximab arm. Again, patients with Siltuximab had significant improvement in symptoms, and their improvement in symptoms was occurred relatively rapid. We saw the similar changes in laboratory parameters as in the Actemra study, with improvement in CRP. Fibrinogen came down nicely, SID rate came down, and hemoglobin went up. We also looked at the effect of prior therapy on the ability to respond to Siltuximab. And there were patients both in the Siltuximab arm and placebo who had received prior therapy with steroids, cyclophosphamide, vincristine, and there were also Rituximab-treated patients. And again, it did not make that much difference in terms of response rate, whether you were previously treated, here on the right, or whether you were treatment naive. And again, the time to treatment failure was superior, whether you were in the Siltuximab arm, whether you were treatment naive or previously treated. Patients also filled out questionnaires, and there was a questionnaire dealing with multicenter Castleman's disease-related symptomatology. These are patients' reported outcomes, and a higher score here means improvement. And these patients felt physically better, had better vitality, felt emotionally better. So they had benefit of this particular treatment. Then the phase 1 study, we did a long-term safety study. The drug is well tolerated. It takes away some of the growth signal for the thrombopoiesis. So a lot of patients have a platelet count which is between 100 and 150,000. You can get some hypercholesteremia, some need an anti-cholesterol drug, some vague skin rashes you sometimes see. But in general, this is very well tolerated. And you also do not see any weird opportunistic infections. There were 19 patients in this extension study. They've been on drug for a mean of 5.1 years, with nearly 3/4 treated over 4 years. One of my patients has received more than 150 doses of Siltuximab. Also, we did not see an increase in adverse events over time. So in the majority of patients, this drug is well tolerated, and when you respond, you appear to do well and not lose response. So what are the limitations of targeting IL-6? Well, as David already very eloquently said, IL-6 is up in a number of patients, but we don't know why. So we can neutralize it with these with Siltuximab or block the IL-6 receptor with tocilizumab, but it's not curative. And the Japanese experience has shown that if you stop the drug, that patients will relapse. With the Siltuximab study, we have had an interruption in the drug supply, and some patients started to get symptoms again. We're now trying to space out the intervals from 3 to 6 weekly dosing, and some patients really need to be dosed every 3 weeks, so it's not a curative treatment. Then there are non-responders. There are patients who need something beyond Siltuximab, low-dose steroids. In other patients, the disease is just too aggressive, and they need some form of chemotherapy as well to get the disease under control. Then there are patients with a more indolent disease where IL-6 doesn't appear to be the major player. And there are rare patients who do get these cytokine storms and where IL-6 does not appear to be the crucial factor. Rituximab is very effective for HHV-8-related disease, and an HIV positive and HHV-8 positive has improved disease control and made a major improvement in preventing progression to lymphoma. I think rituximab has been around for a long time, so oncologists are very familiar with it. They use it for all forms of lymphoma, autoimmune disorders. So it's often the first port of call, but it has not been systematically studied. The fairly limited data in HIV-negative disease, it's perceived as single-shot therapy, like you give 4 or 8 doses, and your patient goes into remission and you don't need to worry about it. In my experience, that is not the case. I think that the patient who might be candidates for rituximab do not have any or little excess IL-6, no major inflammatory syndrome, and I call them POMS like MCD. Obviously, you could argue if you fail tocilizumab or siltuximab that you then need rituximab. In my experience, the patients who fail that are too sick and need chemotherapy. I will say that this is my personal experience, and if you work in a tertiary referral center, you do get a selected patient population, so it might be a little bit different in the real world. This is a patient who had multicenter Castleman's disease, who responded very nicely to rituximab, but then eventually relapsed and was treated in the Siltuximab trial. And this is a PET scan. PET scans are, in my view, very useful in monitoring. You can see activity in the lymph nodes if the disease flares up. At baseline, PET scan is useful too. Very hot nodes would lead you to suspect that there might be lymphoma there. I use sort of an arbitrary cutoff of an SUV of 6. If it's higher than 6, I start to worry about lymphoma. And the other way I use the PET scan, I try to, if possible and accessible, biopsy the hottest node. So it is useful for a diagnosis and for follow-up, but it has not been systematically studied, PET scanning. Who should not get an anti-IL-6 agent or rituximab? I'm very dogmatic about that. I think if you have coexisting POMS with a progressive polyneuropathy with a motor component, then you don't respond to these agents. And I've tried it. And in my view, they require a melphalan-based autologous stem cell transplant in a majority of patients. Obviously, I'm talking here in the presence of Dr. Dispenzieri, who's really the world's POMS expert. And she may have words of wisdom relating to this as well. So what do we do with the IL-6-driven idiopathic Castleman's disease? Now, this is my approach. There are certainly other people in other centers who do it differently. I start with an anti-IL-6 agent. If there's a response, you continue. There are some patients with an inadequate response to the IL-6 targeted therapy, and they may need some additional steroids, some low-dose prednisone, and that may get them in remission. If they're really sick in a major cytokine storm, I give them chemotherapy, and then some form of maintenance, which could involve an anti-IL-6 agent. If they progress, you could consider a stem cell transplant, or you can become creative and use drugs like Velcade or other agents. The more POMS-like disease, which is more indolent and without major cytokine storms or major symptomatology, I think you could try Rituximab and dexamethasone there. If you get a good response, you can stop. If there's an inadequate or no response, then you can consider giving an investigational agent. Usually people would, I think, first go to drugs like bortezomib, lenalidomide. There are now also novel, more potent anti-CD20 antibodies. And there's a drug called ibrutinib, which has not been tried in this setting. That might be interesting to do. And I think I will leave it here.